Dr. Ciaran Scallan, who is an assistant professor at McMaster University and a staff respirologist in St. Joseph Healthcare Hamilton and Hamilton Health Sciences. He runs specialty clinics for patients with interstitial lung disease, in addition to the new satellite lung transplant program at St. Joe's in partnership with the Toronto General Hospital. His research interests include patient-reported outcomes, health-related quality of life, basic mechanics and interventions for pulmonary hypertension and interstitial lung disease, and early phase clinical trials. Dr. Scallan is also a recipient of the 2020 research grant from the Canadian Pulmonary Fibrosis Foundation. And so I'm honored to introduce you to Dr. Ciaran Scallan. Hello.
Thanks, Sharon. And thanks so much again for the invitation to speak again this year. As I was saying before, it's really an honor to be a part of this. So delighted to be here. I'm just going to share my screen so we can get started. Looks like number one. Hopefully this works. Good. Can you see the slides there okay?
Yes, thank you.
Perfect. Okay, great. So I'd like to talk today about lung transplant for interstitial lung disease. And I think as the title of the session said, that we're going to discuss as well the influence of COVID-19 on transplant activity and transplant patients. Really, I think I'm going to gear the focus today, as I did last year, on really the pre-transplant setting, which I think is probably most relevant for the audience today. I won't spend a huge amount of time on COVID. I think it's consumed most of the rest of our lives. So I'd really like to focus on the typical transplant journey, but of course, keeping in mind how things have changed somewhat with the influence of COVID. I do have some disclosures, including the research funding that Sharon just mentioned, but nothing relevant to what we'll be discussing today. So I'd like to talk about the selection of lung transplant candidates and the assessment process. And go through it in some detail, and I'd be, again, more than happy to answer any questions that anyone has at the end of the talk, or anytime during. Feel free to interrupt at any point. I'd also like to discuss what to expect after listing and transplant, and then a discussion of some outcomes after transplant, and then, as I mentioned as well, transplant in the time of COVID-19. We'll be discussing some hard data points, and really I've tried to frame this in a very similar way to the discussion that I have with patients in the clinic when we talk about transplant as an option, what it means, what to expect, and what people go through. So I'll do my best to frame it in that way. And I will say as well that, if it is something that's part of your care path, meeting and discussing with someone who's gone through that experience is invaluable as well. So I'd strongly advocate for that happening also. So just a brief background, and you'll get many other talks as part of this series about all kinds of interstitial lung disease in much greater detail. But in very basic terms, it's, the interstitium of the lung provides the scaffolding or structure that allows our lungs to maintain their structure and move throughout the cycle of breathing in and out. And it's problems with this scaffolding that causes problems for the patient in many ways. There's many causes of interstitial lung disease, again, which will be covered in many other sessions. But in very basic terms, again, what really happens is the lungs become very stiff, and oxygen has a very difficult time moving across those membranes. And of course, oxygen is the fuel we need to run all of our systems. And so when that oxygenation is impaired, we end up with end organ damage and ultimately leading to decreased quality of life and ultimately death. The treatment of ILD is very complex, of course, depending on what type of interstitial lung disease you may be diagnosed with. But there are some fundamental principles, of course, quitting smoking if that's an ongoing concern, maintaining up-to-date vaccinations, for example, influenza, pneumonia, and of course, COVID-19, engaging in pulmonary rehabilitation or using supplemental oxygen if necessary. Acid reflux is a very common occurrence in many types of ILD, and identifying and treating that can be very helpful. And then, of course, there are specific medications which are used for certain types of interstitial lung disease. And as many of you know, the pool of eligible patients is rapidly expanding, but the antifibrotics nintedanib and pirfenidone, again, are growing in use across indications. And in certain disease states, modulating the immune system may also be very helpful. Beyond our approved therapies, of course, there are many research studies and clinical trials. And this is really where COVID has had a significant impact in decreasing our ability to enroll patients in in-person clinical trial studies. But again, we're hoping to ramp those up as we get this horrible pandemic under control. And then at the very bottom right here, the purpose of our talk today really is lung transplant. an end-stage lung disease for any cause, transplant is an option in the right person as a possible management strategy for those people who have failed all other options. So specifically talking about interstitial lung disease today, ILD is actually now the second most common reason for lung transplant. At our program, it's up near the top for the most common indication and is rapidly growing, and I'll show that shortly. And we know that with patients with ILD, we actually show improved survival. So unlike patients with COPD, the data doesn't really show increased life expectancy, but does show improved quality of life. We definitely improve survival after successful transplants for most patients with interstitial lung disease. So I'll be pulling some data from, this is the International Society of Lung and Heart Transplant. They collect data from most centers around the world to pool it all together. It's collected on a rolling basis, and it's a wonderful asset to have to really show what the pattern of behaviors are, not only in transplant activity, but outcomes as well. So I'll show a little bit of that to try and give us some more meat to chew on as we sort of work through some of these different issues. So this is all transplant activity across all registered centers from the time of 1990 to 2017. This is the most updated, sort of easily presentable data that we have. And you can see that as we move from left to right, the different colors indicate all the different indications for transplant. And you can see that the blue and red bars are those patients with interstitial lung disease. And as you can see, all transplant activity has increased, but the proportion of patients receiving transplant for these indications has increased as well. And we project that this proportion will continue to grow. So it's a very important population when we're considering lung transplantation. This is the number of transplants by year and procedure type, sort of double lung transplant and single lung transplant. We won't focus too much on the difference between those today, but again, this graph just represents how there's been a gradual increase in transplant activity over time. Again, I don't have it graphically displayed, but you'll see a marked drop-off in transplant activity, of course, since 2019, and we'll get into some of the nuance of why that is a little bit later in the talk today. As Ciaran mentioned, I'm affiliated and work with the Toronto Lung Transplant Program, and so again, my bias is that I'll talk about some of our local practice and local data. Some of this will vary from center to center, but I think the core principles we'll discuss today, I think, are generally, universally applicable. This is our local transplant activity from 1983 to 2019. Again, the general trend reflects that worldwide, where there's been a gradual increase and actually for us quite a rapid increase since sort of 2010 to 2013. In 2019 there were over 200 transplants performed in Toronto, which makes it the busiest lung transplant center worldwide. So when thinking about lung transplant and interstitial lung disease, there's a number of very important questions, and I think top of mind when we're meeting someone for the first time is who makes a good candidate. And it's quite a complex question, but we can break it down into some simple components. So of course we need someone to be sick enough. So we need someone to have advanced enough pulmonary disease with enough functional impairment, risk towards survival and impaired quality of life to consider transplanting organs as a possibility. Of course, we want someone to be able to benefit as well. So we have to make sure that you don't have any other major diseases which could impact your survival post-transplant and the potential to participate in a pulmonary rehabilitation program. We need to make sure that a person is optimized for surgery. And by that, we mean a number of things, but definitely no smoking for at least 6 months and to be an optimal weight. So BMI is one indicator we use, and we use a rough range of about 18 to 30. But as part of our multidisciplinary team, we have physiotherapists and dietitians and many other individuals. BMI again is a crude indicator, but we need people to have good muscle strength and of course not be either over or underweight when considering undergoing a major thoracic surgery. As part of the transplant process, there are a lot of complicated steps to follow both before and after. And we need to make sure that someone we're considering this procedure is able to follow up on all of these requirements and recommendations. So there's a number of medications, clinic visits, and of course, having a really solid support network to support you through what's a very difficult time. So when do we consider transplant? So, we're seeing you in the ILD clinic and we're thinking about your disease and how things have changed. What are some of the indicators that for us really raise the flag that we should start this conversation? I will say that, a lot of us advocate for early discussion of this possibility because again, there's a very complex process involved in evaluating someone as a potential candidate. And as many of you know, interstitial lung disease can be a very unpredictable disorder. Lung function can change unpredictably or an acute exacerbation can occur, which changes the equation completely. So I will say, generally speaking, early discussion is always important, at least to make people aware and start education and perhaps collecting some data that may be helpful in proceeding through the process. But some of the triggers that we see as ILD physicians are people who obviously have severely abnormal pulmonary function tests. So that forced vital capacity or the gas transfer capacity that we see on the PFTs you do every once in a while, if those start to change or are significantly impaired, that would certainly be an indicator we should consider transplant. So not only the numbers themselves, but if they're changing over time. If the amount of oxygen needed to maintain saturations in a normal range or an acceptable range are increasing or are very, very high, again, that's another indicator. The development of pulmonary hypertension is an indicator usually that there's significant progression of the underlying parenchymal and pulmonary vascular disease, and that as well would be a significant marker for us to consider the transplant discussion. And then, of course, if your quality of life is markedly impaired because of your lung disease, that would be another very solid reason to begin the discussion. So there are four big questions, I think, that come from people who have been approached about transplant or are thinking about transplant. And I'd like to cover each of these piece by piece today to try and address some of these big questions that come up. So question number one is, why is it such a big deal? Why do we have to go through all this, all this testing and discussion, and why are we having even a talk today about it? What is a lung transplant assessment? So if, I'm recommended, and I think that this would be a good thing to proceed with, what does this involve? What does it mean to be listed for transplant? And then after transplant, what would my new life be like? So let's break it down into each one of these questions and go through these in some detail. So first, why is lung transplant such a big deal? Well, there's a number of considerations, and first of all, there's not enough lungs to go around. So, organ donation, as many of you will read about in the news from time to time, our organ transplant societies are always looking for ways to increase awareness and make people, reconsider, whether or not they'd be willing to be organ donors. But it's a limited resource and a very precious one at that. And so with any limited resource, we have to be absolutely sure we're using that in the most beneficial way possible to provide the most benefit to the most people that we can. Lung transplantation can place a very heavy demand on not only patients, but their families and their support network. It's a very challenging process and really requires a lot from people going through. And so, we need to sort of communicate and make sure people understand what this involves. The next is that lung transplants, the organs themselves eventually stop working. So, unfortunately, we're not able to restore life expectancy to normal. Unfortunately, there's just a slow degradation of transplanted lungs. We call this a chronic lung rejection or chronic allograft dysfunction, which can progress over time. And so, you have to think of this as sort of a trade. You're trading one disease for another, albeit one that should improve your survival and give you much better quality of life. So moving forwards, what is a lung transplant assessment? So you've been referred to a transplant respirologist and you've had a chance to discuss and you'd like to proceed with an assessment. So there's extensive testing, and this is usually done between where you're based with your referring physician and the transplant program. And it's really an evaluation of your overall health. Again, we want to make sure that we know everything about you that we can, and that we identify any other major problems and can address those if necessary. So we do a thorough evaluation of your heart, your lungs, your kidneys, really all your organs. And it's more than just tests, really. We like you to meet our entire team. And as I mentioned briefly before, we have a very large multidisciplinary team of, just as a few examples, physiotherapists, respiratory therapists, dietitians, social workers, nurses. We have a very extensive team who are all involved intricately with the transplant process. And through this assessment period, you have various visits with different members of the team. And it's a two-way street. So you get to learn a little bit more about transplant from different people's perspective, and we get to learn more about you and your support network and your health and your history. Because again, as I mentioned, we need to get to know you as best we can to decide if this is a good option. So once you've gone through all these tests and meetings, we sit down in what we call an assessment meeting, where it's a multidisciplinary discussion with every member of our team. It's quite a large group. We have a presentation of an individual or a patient's situation with all of their background history. And then we have a discussion. We talk about where this person's come from, what they're dealing with now, and whether or not we think that this might be a reasonable option for someone to proceed with a transplant surgery. If there's no problems identified and we think that this might be a reasonable option, then someone would be listed for transplant. And that usually happens within a few weeks of the meeting. And I'll go through a little bit of a flow chart to sort of lay out graphically how the process works with some sort of basic timelines as well. So let's say you've gone through this whole process and you've gotten the green light and you're on the transplant list now. You've got the call and you're on the list. So there's a couple of expectations that come with being in this situation. So you need to live within close proximity to the hospital. We say about 2.5 to 3 hours. Those who live further away usually have to move closer to be within reasonable range. And the reason for that is when an organ becomes offered as a potential for transplant, the clock starts ticking because there's these ischemic times and things that are very important to minimize. And so we need to have people in and ready to go in a very short period of time. You must be able to stay as healthy as possible. And of course, living with a chronic disease like pulmonary fibrosis is very, very difficult. But of course, we discourage any unhealthy habits, shall we say, and of course, engaging in an ongoing rehab program. We usually say about 3 times a week. I'll allude to it a little bit later, but as many of you know, things have changed with COVID. There's a lot of virtual options and things, but to say the very least, ongoing regular exercise is extremely important. And then, of course, you must wear a pager. I put that in quotations because we don't really use many of those anymore, but you must have your phone or be contactable at all times. Again, for that reason that you have to present to the hospital in a very short period of time if you get that notification that there may be a potential lung available for transplantation. Very common question is, how long do people wait? So you've gone through this whole process, you're put on the list, and how long does it take to get a lung transplant? And that's a very complicated question. As you can imagine, there's a whole list of people who are on, waiting for a transplant, and there's a number of issues that come up, both from the list perspective and of course external pressures, COVID-19 being an example. The wait time can range anywhere from 2 days up to 2 years, but on average, and again, this is pre-COVID, about 2 to 3 months seems to be the average wait time once you're activated on the transplant list. So I sort of laid it out, and thank you very much to Dr. Binney for helping with this slide, but this is a very basic graphical representation of the journey from referral all the way through to listing and transplant. So the top left, you can see that a referral is activated. And again, going back to some of those things that we would recognize in the clinic may trigger this referral. The wait time for being seen, I put 4 months there. We try to target a lot less. So once you've been indicated as someone who should be considered for transplant, we're now targeting sort of around more a month to be seen by somebody from the program. You'll have a visit with a transplant respirologist, and it's again a two-way street where we get to know you and you get to know us, and we communicate back and forth whether or not we should proceed with the assessment. And that's, of course, as I said, the full process where you go through lots of testing and visits and other investigations. Once that's done, you go through the assessment meeting, and there's a decision made whether you're suitable for transplant or not suitable. And again, not suitable, you would talk to your referring provider about other treatment options or other things. But if you are considered to be suitable, there may be a situation where you're still too healthy to proceed with a transplant. So, again, with interstitial lung disease or pulmonary fibrosis, we know that things progress over time. But again, as I mentioned, timing is extremely important. So we may think that although you would be an excellent candidate, it might be a little bit too early. And so we'll see you every few months to make sure things haven't changed too much. But we won't necessarily put you on the list at that specific time. However, if we think that your lung function impairment or quality of life is impaired enough that it's reasonable to list, then that process takes place and you're on call basically and called in for a transplant. So what does that look like? So your transplant pager goes off. What is life like with new lungs? And we're going to go through the good, bad, and the ugly. And I think there's a lot more good than anything else, but we'll go through everything as best we can. So you're in the hospital and your transplant's done. On average, patients are in hospital after their surgery for about 2 weeks. You start in the intensive care unit once you get out of the operating room. And again, you sort of start to, as things improve slowly and you get back on your feet, you move towards the general hospital ward. And we really aim, if everything goes well, to have you back home in about 2 weeks. Most patients no longer need oxygen, and I would say almost all patients no longer need to use oxygen when they leave the hospital. And at about the 3 to 6 month mark after your surgery, we hope to have you back in your own home for those who have had to move, and really back to living as normal a life as possible. It takes about 12 months for the new lung or lungs to reach their maximum function, but really at about 3 to 6 months, we hope to have you back on your feet and doing a lot of things that you really want to do. So those are what we expect from someone who goes through this process. Of course, there are some challenges. Life will never be the same. For those of you dealing with really challenging lung diseases requiring lots of oxygen and a lot of limitation, it's really a small adjustment in terms of things, but there's lots of clinic appointments, and that can place a big demand on yourself and, of course, your support network. There's a lot of testing that's required. You're on a lot of medications, especially those to suppress your immune system. There's 3 different medications that we use. And we have to frequently monitor your blood work to look for complications and the levels of these drugs, which require some adjustment as well. We do lots of CT scans and bronchoscopies on occasion, and that's to look for any evidence of rejection of the new lungs or infection. So there's a lot of visits and testing that's required in the post-transplant life. I alluded to those medications that you're on, and while they're absolutely necessary for us to maintain the health of your lung to reduce the risk of rejection, there are some side effects, and these can add up over time. The more common ones that we see are damage to the kidneys from some of the drugs that we use. There's problems with high blood pressure or cholesterol. There's a risk for developing or worsening of diabetes. And of course, you're at risk for opportunistic infections. So as part of the pre-transplant process, we make sure that you're up to date on all your vaccinations. But there are some infections that we provide prophylactic medications after transplant for. And then there are infections we can't prevent, but we have to be very vigilant for those occurring. Unfortunately, the risk of cancer is increased when you suppress the immune system. Our immune system is very involved in regulating healthy cell turnover. When you modulate that, your risk of cancer can actually, unfortunately, increase. The most common that we see in our post-lung transplant population is some kind of skin cancer, so you have to get checked regularly. But other things like leukemia or lymphoma can also occur, and so we have to be very vigilant for the occurrence of any of those. But that's always something that we would discuss in detail when you meet us in the clinic. And then as well, I alluded to this before, but there is the inevitable development of something called chronic graft dysfunction, or this bronchiolitis obliterans syndrome, which you may read about. And eventually the lungs just won't work as well as they did when we first put them in. And this is the immune system just slowly having a negative impact on lungs over time. And we see this gradual drop off in lung function. And this is graphically represented. So again, this is taken from that database that I mentioned before, but you can see that, ignore the different color lines, but really look at the primary. So this is the blue line here of those patients receiving their first transplant. Unfortunately, at about 5 years after surgery, about 50% of people have some evidence of chronic rejection, and you can see that that just continues to increase over time. So moving to outcomes. So what to expect, and really let's talk about some numbers. So really the 1 year survival after transplant is over 90%. Again, I always tell this to people in clinic, we would never offer this to someone that we didn't think would have a good chance at surviving the surgery and getting out of the hospital after it's done. The median survival, so about half of people who receive a transplant are alive about 5 to 7 years after they receive their transplant. And that's fairly accurate for people with interstitial lung disease or pulmonary fibrosis. Depending on different indications for transplant, that number may be a bit different, but I think for the purposes of today, I think that's a reasonable number. Unfortunately, the older you are, the more that curve drops off. And unfortunately, if you're over the age of 65, that number statistically anyhow is only about 3 to 4 years. Now, again, it's a very individual, and then there's a lot of variables that go into this, but I think this is a realistic starting point when we have the discussion about what to expect from a lung transplant. This is the same sort of discussion represented in a graph form. The dotted line is those patients receiving double lung transplants, and the black line is those receiving single. I alluded to this before, that there is a difference between the two, and it's quite an extensive talk that we'll save maybe for another time. But all that to say that this is where that range comes from. You can see that the red lines I've drawn here on the x-axis, which is years, it's the 50% survival, so half of people are alive about 5 to sort of 7.5 years after they receive transplant. There is this conditional number if you look up on the top right here as well, and that's conditional if you survive beyond the first year. As you can imagine, undergoing a transplant and adjusting to that lifestyle, the first year is always the most difficult and where we see a lot of the really acute and difficult problems. If you live out beyond the first year, then your conditional survival, we call it, actually increases quite a bit. So that's a little bit of encouraging data there as well. So again, median survival, about 6 years, to pick the middle of that range. But despite all the risks, I would say for the right patient at the right time, lung transplant can be quite miraculous. Again, a lot of work, and we have to be very careful in who we select to offer the procedure to. But I think that's not an unreasonable statement at all. So it's not all about survival and living. Again, that's an easy piece of data to collect. But I think one of the big reasons we consider transplant too is about quality of life, and that's one of my interests. And it's quite difficult to measure and display in nice simple graphs. But I think this is a very nice one as well, and this is included in that data from the international registry. It's a very busy slide, so I do apologize about that. But this is really patients who are at 1, 2, and 3 years after transplant, and really their functional status. So basically people are sent questionnaires and asked how much they can do. I think the important thing to take away from this is that all the different colors from red up to purple really are people who are able to care for themselves and be independent and do most of the things that they want to do. Those people in purple require some help with normal activity, But I think most people, about 80% at 3 years after transplant, are able to really be quite independent, which I think is remarkable. All right, so moving on to talk about, I guess, the elephant in the corner, about COVID-19 and really the impacts that it's had on lung transplantation. I touched on this last year, and really, unfortunately, not too much has changed, but I think we have a little bit more we've had a lot more discussion and thinking around this, but I'd like to touch on some of the points that we've had and really from a healthcare provider perspective, what we've been having to deal with and how it's impacted our patients. So overall, organ transplant activity has decreased about up to 60% worldwide. And this is taken from various centers around the world who are reporting their activity levels. And I think we're not quite as badly affected here in Ontario, but there's certainly been a major impact on our ability to provide organ transplantation. There's been decreased lung transplant activity for a number of reasons. The first is that we've had a decreased ability to travel because of public health restrictions to recover donor lungs. Most transplant centers will have a fairly large geographic area whereby they send out teams to recover potential donated lungs for our recipients. And so because of the travel restrictions that were put in place, particularly early in the pandemic, our pool of available organs had dropped significantly. Next, we had limited access to critical care beds. As most of you have heard about in the news, as numbers increased during our various waves, the pressure on our intensive care units was increased dramatically. And most of our beds were filled with patients, unfortunately, struggling with COVID-19 infection. And so we really didn't have critical care beds available to use for other reasons. And that's why a lot of surgeries were being postponed or canceled, and transplant was similarly affected. Now, fortunately, transplant was prioritized as a very important thing because of the very vulnerable state of many of our patients. But inevitably, if the beds are full and you have nowhere to put anyone, you really can't proceed with those surgeries. And so again, our ability to do transplantation was severely impacted. And it's not only the intensive care unit, but there's overall pressure on the healthcare system. So, for example, even something as straightforward as coming into the clinic, we weren't able to do. During some of these waves, our clinic spaces were closed. Our access to lung function testing or CT scans were severely limited. And so we were really struggling with monitoring our patients' disease progression, or really even just seeing people to discuss, even the concept of transplant for those in the early phase. So really there was a huge cascade effect from a lot of these restrictions on our ability to provide care. And again, this extends to many people in many fields, but transplant specifically, we were markedly slowed down. I try to find a silver lining in everything, and I think there's been a few good things that have come out of this. First and foremost is the rapid expansion of virtual care. And I think for many of you who are on a lot of oxygen and getting around even short distances is very challenging, the ability to get high quality remote care at home has been a fabulous asset. And I think that, this has been a growing interest for a number of years, but COVID had really accelerated not just physicians, but, the ministry or those people who fund healthcare initiatives, really the value of providing virtual and remote care. So we've been able to do some clinic encounters, and a lot of our pulmonary rehabilitation programs have engaged in virtual programs for those patients which it's appropriate. And so really it's provided a wonderful ability to provide high quality care at home. There are some other things in development, a lot of, sort of more advanced remote monitoring systems and all these really neat research initiatives to provide, again, more high quality monitoring care at home. And so again, if we're going to look at any benefit from this horrible pandemic, accelerating these initiatives has been one that's been very nice to see. So this is from a consensus statement that was put out by the Society of Heart and Lung Transplant, and really just talking about the pressures on transplant programs and sort of our ethical and practical approach to transplant during these pandemic times. This is a graph showing really, the very dark bold curve, the dark line curve there is the number of cases in the community essentially. So this would be reflective of a typical wave that we'd see. So for example, this is our third wave that we experienced here in Canada a number of months ago. The dotted lines here are transplant activity basically. And there's different phases that they've attributed to each of these sort of parts of dealing with a surge of cases of any pandemic. So there's the anticipatory stage. And you can see that in anticipation of seeing a lot of patients coming into hospital, you can imagine why transplant activity would drop off to prepare and make beds available. Of course, as cases become more active and the number of patients presenting to hospital grows, there's the inevitable pressures, as I mentioned, on ICU and other clinical spaces, and naturally, this transplant activity decreases. As we get these issues under control and the number of patients being admitted plateaus and then are eventually discharged, our capacity increases again. The difference between curves C and B are really what we were trying to do was mitigate or minimize that impact on our programs. While there will be an inevitable decrease in activity, we were trying to develop a strategy whereby we would limit the amount of impact on transplant activity as best we could, despite the pressures on the hospitals otherwise. And so this really called into question as to how we really go about recipient selection during a pandemic. So you can see that these are boxes sort of displaying different approaches to candidate selection. And on here is the urgency of the procedure. So from low to high. So someone who's very, has a disease but is doing quite well, to someone who's rapidly deteriorating, for example, admitted to hospital with a bad infection or exacerbation. This gradient of color here really is on the top is someone who's too sick or too well for transplant. And in the middle are those patients who really are at the very right stage of their disease. So very robust and healthy, but obviously very impacted by their disease. And there's sort of different approaches to doing this. So you could say, well, let's only transplant those patients who have very, very high urgency for transplant. So those people who are deteriorating rapidly or are admitted to hospital or are needing, very advanced life support to maintain, to sustain life. The alternative would be to only transplant those patients who are very low resource intensive. So those people who are very well and we think will sail through surgery and get out of the hospital very quickly. But as you can imagine, in both of these strategies are disadvantaging one group over the other. And so we really try to provide a balanced reduction of activity by considering both those patients with high urgency needs and those who have low resource requirements. And as you can imagine, it's a very challenging ethical and pragmatic issue for us to really provide the highest quality care during a very demanding time. COVID's had a lot of impact on other parts of things as well. The impact of vaccination on immunocompromised individuals, providing lung transplant for those people who have had COVID and have long-term lung damage. And these are all things that we're learning about more and more every day. And so, again, as this pandemic continues into, unfortunately, probably the next year or two, I think our approach to this is going to continue to evolve. But again, hopefully with more refined public health measures and increased vaccination rates, the overall pressure on the healthcare system will decrease and hopefully not impact our transplant program activity as much as it has in the last 2 years. So to conclude what I've discussed today, I would say that lung transplant is a complex and resource-intensive endeavor, but it does have the potential to provide excellent outcomes in carefully selected individuals, and that's for both survival and for quality of life. Determining the correct candidates is essential to give the best chance of a good outcome, and I think education and understanding is integral to that process. And as I briefly mentioned before, I think starting this early in anyone with pulmonary fibrosis is very reasonable. You don't always need to be referred to a transplant center, but attending talks like this, or perhaps doing some reading as well on your own, to get yourself a little bit more educated on transplant would be essential. The other high value proposition would be to, in your support groups, there's always somebody around who's either going through or been through a transplant, and leaning on them for their personal experience is absolutely invaluable. I tell everyone to try and do that. I can talk all day about, the parts of things that I see, but to really speak to someone who's been through it themselves to get a really good understanding of what's involved, I think is absolutely essential. As I hope I've alluded to today, life after lung transplant is not without challenges, but it definitely offers improved survival, and it markedly can increase quality of life. And then finally, we discussed about COVID-19. So it's had impact significantly on lung transplant activity, and we have ongoing issues that are expected to continue. But we've developed, I think, a very good framework as to how to approach, transplant activity when there is external pressure on a healthcare system in the fairest, most ethical, and most practical way as possible. So I would thank you to Dr. Shapiro and Dr. Binney. They were really helpful in providing me with some background and from some slides to put this together, and have been a great support to me through other things as well. And I'd be more than happy to take any questions you might have about anything involved with transplant at all. So again, thanks for the invitation today. It was a delight to be here, and any questions are welcome.
Great. Thank you, Dr. Scallan. So we have a question for you. Nancy has asked, can you tell us what's the average waiting time now for a transplant patient during this pandemic?
Yeah, sure. Thanks, Nancy. That's a really good question. It's hard to give you a single number. I would go back to that slide I showed about the curves and the waves of pressure that we've experienced during the different waves of this pandemic. Unfortunately, as each surge has arrived, each of them have been actually quite different. And so they've sort of exerted different levels of pressure on our system. And so during each of these waves, there's been this rapid decrease in our transplant activity which has dramatically affected not only our wait list, but the patients on that wait list as well. So while I quoted, I think 3 months to you in the normal sort of quote unquote pre-COVID times, I would say at least twice that long now we would quote as an average wait time, with the caveat that this has been so unpredictable that we have no idea what further pressures on the healthcare system might provide.
Okay, Dr. Scallan, can you also answer about the COVID vaccination and the impact it might have for those who've had lung transplant?
Sure. Yeah. Thanks, Sharon. So you may have heard in the news recently that the National Council for Immunization, it was a little while ago, but recommended a third dose of the COVID vaccine as a quote unquote booster for those patients who have received transplants. And the issue there is that, any patient on drugs that modulate the immune system, if you're trying to stimulate that immune system, you're not going to get the same response as you would for someone who's not on those medications. And so the first impact we noticed was that, if you may remember, there was various recommendations about the timing of the first and second dose. We don't have a perfect way of telling how our bodies respond to the vaccine. So you can check antibody titers to both infection and vaccination. But that's just one tiny component of our immune system. There was a lot of really good work done in Toronto, actually, looking at transplant patients' response to doses of the vaccine, not only for timing between the first and second dose, but then their sustained immune response after. And we actually showed that, well, not we, I wasn't involved, but the team at Toronto showed that circulating levels of antibodies and some other markers of immune response were significantly decreased in transplant patients a number of months, I think it was 4 to 6 months after receiving their second dose, which prompted the recommendation by NACI and now Health Canada for transplant patients, among others, to receive a booster dose of the vaccine.
Okay.
We're not recommending it currently for healthy individuals, but we are starting to recommend it for people on other immunomodulatory drugs, things like rituximab or other things as well. So I would pay very close attention to any sort of major public health announcements that are made. And of course, talk to your respirologist if you have any questions about whether or not you would be a candidate for a booster.
Okay. Dr. Scallan, another patient is asking that his breathing changes from time to time and sometimes changes daily. Sometimes his lungs are fine, but the next day his chest is heavy and has trouble breathing. He doesn't want to go to the hospital for it, but would he be ready for transplant?
Yeah, thanks, Sharon. That's another really good question. So I think, as I alluded to before, there's a number of things that we look at when we are trying to consider someone's candidacy for proceeding with the transplant process. So I would say to whoever asked the question, the fact that you're thinking about it is great, and the fact that you've attended today to get a little bit of information about it is wonderful. I can't provide any specific guidance about your situation, but it's certainly, from what you've mentioned, you're struggling with a lot of symptoms from your lung disease. If it's fluctuating quite a bit over time, there may be some things you could discuss with your respirologist about managing your symptoms, but it really would require a full evaluation of your lung health. So your lung function testing, your CT scans, any other cardiac testing you've had recently. So, again, if it's a question that's come to mind, I would take the time to talk to your ILD or your pulmonary fibrosis physician about transplant as part of your care pathway. And again, they may say things are a little bit too early, but here's some reading about it, or maybe we should consider a referral. But I think it's a great thing to ask whoever's providing your care.
Dr. Scallan, someone from a support group said that they know someone who just received a transplant this past March. They were expecting a double lung, but they only received one. What makes that decision? Like, what goes factors whether you get two or just one single lung?
Yeah, that's a really good question, Sharon, and one that comes up really often. There are certain reasons why. So I think to start at the very beginning, it's possible to either do one or two lungs, so a single or a double lung transplant. So you can actually transplant a single lung and leave some diseased lung behind. Our bodies have an amazing ability to move blood away in our lungs, away from areas that aren't working very well. And so they can't do that completely, but if you do have one lung that's healthy and one lung that isn't, really the healthy lung can perform all the functions required to maintain life and maintain a quality of life and not need oxygen. The decision to provide a double or a single transplant is quite complex. There are a number of reasons why you could only receive a double. If you have a history of certain chronic infections, if the pressures in your lungs are very high, or something called pulmonary hypertension, that would be another reason to only receive a double. The conversation around single versus double is quite complex, and it involves, obviously, making sure that we do the most good for the most people possible. So if we think that you would do well with a single lung transplant, and we have someone who's offered 2 lungs for potential transplantation, we could actually benefit 2 people as opposed to 1. There's a lot of debate in the transplant world about single versus double, but our practice has been that sometimes you'll be listed for both. So if an offer comes up and there's 2 lungs available and there's no one else that's a match, you may get both. But if there's 2 people who match for those lungs and you're appropriate to receive a single lung transplant, then you may proceed with that as well. So you may be a candidate for both, and you may not know which one would take place. I will say that we would only offer a single lung transplant in cases where we thought it was appropriate. And so it's a very carefully considered decision.
Okay. Someone else want to ask, what is the best time for referral? Her spouse has a CHP, and she's read that indicated referral should be made at diagnosis, right? But her spouse was only referred after 6 years of diagnosis. Is there any reason for that, or?
Sure. No, that's another really good question. As many of you know, there's when you talk about interstitial lung disease, it's an umbrella term for a huge number of different disorders, and people present at various stages of disease, and some diseases will progress in different ways than others. It's very difficult to sort of give a very hard and fast yes, you absolutely have to do this every time. Again, as I mentioned before, I advocate for early consideration of transplant for people. And that doesn't necessarily mean a referral to a transplant center. I think, as I mentioned before, really getting educated about what transplant means and how it factors into managing your lung disease is extremely important. And we're always, discussing with our colleagues in respirology or in interstitial lung disease clinics about the timing of referral and assessment and all these sorts of things. So there's no hard and fast rule. If someone has very mild early disease that when they're initially seen and diagnosed with ILD, it's totally reasonable to try all the various therapies that we have in our pockets to treat that disease, because very often we can stabilize things and things can continue on for a very long period of time in a very stable fashion. However, if you are on treatment, for example, for HP, and you're on a medication for HP, but things are decreased, or your lung function is changing or declining, then that would be a point in time to consider referral. So I never think it's too early to think about it or talk about it, but people who provide care for ILD patients have a lot of experience with this and really have a very good feel on when the appropriate time for referral is. Very often, if there's someone they're worried about, they can always reach out and have a discussion and say, should we start now? Should we start later? So this is a constant conversation we're having. But again, I would advocate for educating yourself as much as possible. Even from the time of diagnosis is very, very reasonable.
Okay. The past patient that asked the previous question wanted to let you know that they're on an antifibrotic drug, and they're hoping for transplant, and they've been on oxygen since this last December. Now, they've had this disease for 8 years now. Does that mean it'll progress very rapidly now, given the deterioration in their lungs, and that they'll be a good candidate for a lung transplant?
Yeah, potentially. Again, Ciaran, I would hesitate to comment on anyone's specific situation, but certainly, yes, that's one of the indicators. So if someone wasn't on oxygen and now does require oxygen, that would be a very strong clue that things are progressing. The other variables that we look at are your CT scans, and of course, those lung function testing, so the spirometry or PFTs that you do. Another important variable that I didn't specifically mention would be your 6-minute walk test distance. So some of you or most of you may have done a walk test where we very simply walk you around and see how far you can go in 6 minutes. That's another very important variable that would indicate to us that things are getting worse. There's a lot of nuance that goes into deciding when the appropriate time to refer and list someone for transplant is, and it's quite a multifactorial decision that's made. So again, maintaining good regular contact with your fibrosis physician is extremely important, so they can monitor your disease carefully, so that you can decide on the appropriate time to move forwards.
Okay, Dr. Scallan, someone wanted to know, why does it take women longer to get a lung transplant?
Okay, so that's a good question. That's not necessarily incorrect. So the issue often is that women tend to have smaller thoracic cavities than men. So if you consider women of the same age, just statistically speaking, and just the way that we as humans are built, women have smaller thoracic cavities than men, and the larger percentage of our organ donors tend to be male, and so the lungs tend to be a little bit larger. and sometimes younger as well. So the lungs that are suitable are from younger individuals. So that's certainly probably the biggest variable would be the size of the lung. That's one of the things that you need to match very carefully when offering a transplant to someone. And so size discrepancy can be an issue. It's a really good question. I think it's definitely an area that deserves a lot more study and attention. I don't, there's certainly no intentional, implication of any socio, demographic variable. It's purely really, a size issue in this situation. But a really good question, as I mentioned, something that requires further study to see if there's anything more we could do to optimize that part of things.
Okay. Dr. Scallan, you mentioned your presentation about lung patients often after transplant developing some kind of cancer. Is that something that one should be cognizant of right away after a lung transplant and try to, be prepared for that?
Yeah, absolutely, Sharon. So the risk is substantial. Um, we talk about sort of the elevated. So, we would compare you to someone who didn't receive a transplant and is not taking the medications that you did. So the risk for cancer is markedly increased when you're on these immunosuppressive medications. I think we typically see those onset several years after your transplant. We don't usually see most malignancies occur within the first year, with some exceptions. But as part of our post-transplant care, we make sure that regular monitoring for any malignancy is maintained. So specific to transplant would be regular skin checks to make sure that there's not been any development of any skin cancer, and then making sure that your up-to-date cancer screening is done. So beyond skin, we don't usually recommend any special testing unless there's been an issue we've identified, but making sure that absolutely you're up to date on all of your regular cancer screening that we recommend for everyone. Some of the more like I mentioned sort of the blood malignancies we can monitor with blood work, which you're getting done very frequently anyhow. And so again, as part of our post-transplant care, we remain very vigilant for those, but most of them we usually see occur a little bit later than the immediate post-transplant period.
Dr. Scallon, someone wanted to know when you have a lung transplant, does it fail very often? Because they know someone who's actually waiting for their second lung transplant because their first one didn't work out after 6 years.
Yeah. Another great question. So yes, as I mentioned before, the issue with lung transplant is that they eventually stop working over time. To be very simplistic about it, and that's because of this slow rejection. It's very individual. Different people experience it in different ways. Some quicker, some slower. And then if you have issues along the way, you can get episodes of acute rejection, or if you have big infections, there are certain bumps along the road which can increase your risk to develop this chronic rejection. So I'm sorry to hear about this person who's needing to be listed for a second transplant. That's one of the less desirable outcomes, of course. But yes, everyone does experience some degree of chronic rejection. Unfortunately, some individuals experience it a little bit faster than others. We monitor that by doing regular breathing tests and CAT scans, and of course, being very vigilant for any issues with infection or issues with medications.
Okay, Dr. Scallon, someone wanted to know, is there a age cap that anybody would say, you're too old to receive a lung transplant?
Yeah, that's a really good question as well, Sharon. And we don't have I mean, age is a relative concept, we don't have a solid number cutoff. We don't. Really, we consider the person as an individual, as a whole. So anyone who's referred to us for transplant, we don't have any number. Now, maybe 100 might be something, a lung transplant might not be a great idea at age 100, but, all joking aside, really patients, of any age, we seriously consider, we look at them, their whole profile and go through the evaluation process. So to be direct, at least in our program in Toronto, we don't have a strict age cutoff at this point in time.
Okay. Someone also wanted to know, how you were saying that they have to be physically fit and all those other attributions in order to be chosen for a lung transplant. But what about if they're on oxygen and it's very difficult for them to maintain the exercise and maintaining that good health while they're waiting?
Yeah, I mean, absolutely. So another excellent question. So, being on oxygen is part and parcel of having advanced lung disease. And I would say all, if not all, almost all the patients on our wait list are on oxygen. And it's important, that's an important piece of managing your health, is that the amount of oxygen you're receiving is adequate for what you need. not only at rest, but with exercise as well. And I think that's where pulmonary rehabilitation is a critical part of that care pathway. Our pulmonary rehab teams across the country and across the world are outstanding at providing individualized exercise programs tailored to your ability and your needs. So, if you're on the transplant journey and you're having trouble exercising, go get to a rehab program. You can have your oxygen levels optimized. You can get exercises that are, perfect for what you need in a very safe and supervised setting. But that would be my number one recommendation in that situation.
Okay.
And that's why we require it absolutely as part of your transplant journey.
Okay, great. Is there anyone else that would have any questions for Dr. Scallan today? Because he did a very wonderful presentation. I've learned so much, and it's great to hear that despite COVID, that lung transplants are still taking place, because many patients are worried about organ transplants and being able to facilitate that. So that's really great that you're still moving that ahead. Okay. It doesn't look like anybody else has any questions, so I want to thank you again, Dr. Scallan. Another great presentation. I know last year I learned so much, and this year I learned even more, especially about the various cancers that you can catch after getting lung transplant. So those are all good conversational pieces to have, because I think that, as you presented, everyone needs to evaluate if this is the right thing for them, given everything that could take place or happen, right? So
absolutely, yeah, very well said.
Yes. Well, thank you very much again. And for those of you who want to review this, you can go to hopebreezehere.com in 3 days' time, and this session will be up there for you to review everything that Dr. Scallan had presented today, in case you missed some of the points that he had made. Thank you very much.
Thanks very much. Take care.
Okay.